Thanks everybody for coming on. I know it's evening time for most of you, and I've got a collection of about 9 cases that I think illustrate some of the different things that you may encounter, some of the decision trees you might actually come by as you're trying to decide, number one, whether to use the technology in a particular tumor type, as well as kind of what some of the decisions intraoperatively you might need to make would be as well. I know some of you were on some of the prior talks where we discussed a little bit about where LITT fits into a practice, but I'm going to just start off with a couple of slides that summarize that a little bit without going into nearly as much detail as that prior talk, of course, but just to kind of start us off with some context. And then amongst those 9 cases, I've also sprinkled some little sidebars. And it really is meant to be informal, so if you do have questions, please don't hesitate to ask. I'm happy to address them. You're not going to throw me off. Please don't worry about it. So, in any event, I'm at Duke as Keith just introduced you, and Bill as well. And I wanted to also let you know that we do have some disclosures we have to go through here. So first off, this is the NeuroBlade system disclosures. Obviously, this is a powerful tool that we use, and it's for benefit, but there are some risks, and that's why we want to go over some of these cases. And of course, probably not surprising to any of you as well, I am under a consulting agreement with Monteris. So just a couple of things. I think it is important to start out with the statement that this is not something to be used in every surgical instance for tumors. I don't think anybody would believe me if I said it were. And I think the most important thing then is to understand that it is a tool in your toolbox, just like anything else you use is. So what are some of the limitations? Well, first off, as you remember, this is a laser that gets dropped stereotactically into a lesion, typically down the same trajectory as a biopsy needle. And then there's a driver that is affixed to it, and then depending on whether you have a diagnostic or an intraoperative MRI, you are either staying there and rolling the MRI out, or you are transferring the patient to a diagnostic scanner. And through a single trajectory, you can generally cover a full-size diameter of a lesion of about 3 centimeters, so a radius of 1.5 centimeters out from the laser in any given direction. And so if there are lesions that are larger than that, you can consider a second trajectory with some caveats. And the biggest caveat, which we'll get to in a little bit, is that this does cause edema. It does cause mass effect. And you are not generally resecting this lesion. You are leaving it in place cooked, and if you have a lot of edema around that lesion when you begin, you will have more edema for a period of time afterwards. And so if you decide that cooking a 5 centimeter lesion sitting next to the brainstem is a good idea, you're probably going to kick yourself afterwards. That can be very dangerous. So with that in mind, we are trying to get 100% coverage of that lesion. So we are going to try to cook all of it. There are 2 lines, yellow and blue. Blue represents that we generally use. The white, a lot of us don't look at. But the blue represents cell kill, and the yellow, which is a bit larger, represents essentially kind of reversible heat damage or penumbra. And so the question becomes, well, how much of a lesion do you need to cover to kill it? And much as with resection, there is only retrospective data sets that look at this, but also much like resection, oddly enough, that number seems to be very similarly about 80% before you're really seeing benefit, just like the work of Nader Sinai and Mitch Berger. So obviously, if you get closer to 100, we expect you to get better clinical benefit to that. The heat is not specific for tumors, so you're going to have to watch what you're doing to make sure you're not drifting off into eloquent areas. That's really where the kind of surgical skill comes in. The nice thing is that there's never any question of where you are because the MRI is showing you in real time. The one thing I would say is that a lot of the tumors, and particularly radiation necrosis, however, do seem to heat faster, and it is a little bit harder to heat the normal brain. So you may often see your heat essentially kind of hit its own little wall at the border of lesion and normal cortex, which is nice. We talked about edema and mass effect, so you will often need to keep patients on Decadron for a period of time afterwards. Some relative contraindications, and I wouldn't call them contraindications just as so much as things to be aware of. If you have a very superficial lesion, we tend to not screw the bolt in as far because there is some metal artifact. They are in the process of designing a ceramic bolt to help limit that. So we tend to place the bolt more shallowly, which is not really a word, I suppose, and that reduces some of the MRI artifact that otherwise can obscure what you're trying to do on the with the heat. Heat sinks. Water has a high specific heat set to 1. It's the highest of compounds, right? And so it acts as a heat sink. So if you're trying to heat near water, that water is going to pull heat away from the lesion that's bordering that. And so I call it the rule of V, because generally the kind of water-containing structures in the brain are going to be ventricles and vessels. So if you're by a large artery, that artery will act as a heat sink, so will the ventricles. So if you have a lesion backing up to the ventricle, you may find that the last little bit lining the ventricle is hard to get to a temperature hot enough to kill, but you still may be covering 95% of the lesion or more. You need to be pretty facile with trajectory planning in order to make sure you have a safe entry into the lesion. And of course, there's a learning curve for using the technology. So, all right. So this is just a pictorial representation of some of the things we just talked about. Superficial lesions, periventricular lesions, these are areas where it may be worthwhile to just consider that and push a pause button. Hard stop, like we talked about, large lesions near the brainstem. This one on the right, this was an angiosarcoma met. This needs to be resected. This patient, as you can see, is impending herniation, if not beginning already. If you try to heat that, you're just going to finish the job off there. So as a final summary to this, key points. First off, LITT really does fit well as a tool for surgical site reduction in instances where the therapeutic window for open resection is narrower. In other words, the risk versus benefit. So in instances where you may hesitate to perform an open surgery because of some perceived risk, whether it's radiation-induced wound healing problems, whether it's location of the lesion deeper, whether it's concerns for patients' capacity to handle a large surgery. Those are narrower therapeutic windows, and so we oftentimes hesitate to perform an open surgery. We're often able to offer LITT in substitution for that because it is such a nice minimally invasive technique. But if you still have that desire for site reduction, which is obviously the goal of surgery in all these instances, LITT really is a nice tool for that. And if you believe that site reduction will have benefit for your patient, but you're worried about an open surgery, that is the logical place to put LITT into your toolbox. If you can biopsy, you can often safely LITT, barring the procedural limitations that we talked about on the prior slides. If you can get that biopsy needle down a safe trajectory, you're simply going to replace that needle with the laser catheter. So in the end, when you look at this list of lesions down below, this is typically how I think about things when I approach a lesion. So what are the places for each of these diagnoses? So for newly diagnosed GBM, the surgery is the gold standard. Open surgery resection is the gold standard, but there are places where the gold standard is a little less clear. So deep, difficult lesions, a small glioma in the thalamus or sitting in the internal capsule, you may not be excited about operating in an open fashion there, but you can slip a laser and biopsy needle down a trajectory and get to that safely. Fragile, i.e., KPS around 70, or elderly patients, maybe someone who's 75, 80, you don't want to do large craniotomy. LITT is often a very viable technology in those instances. So what we're talking about here are the folks that you would normally just offer biopsy or potentially think about a subtotal resection, as long as that's not because of the size of the lesion. LITT might be a very nice technology to offer. Recurrent GBM, I think this is a great use. In fact, recurrent GBM, recurrent metastatic disease, recurrent lesions in general, this is a phenomenal use for the laser. These patients have often undergone radiation. They may be sicker and more fragile. For those of you who have done a variety of surgeries on recurrent lesions, radiated tissue is no fun. The dura can be stuck to if they've had a prior surgery, the dura can be stuck to the cortical surface. You don't have any of these limitations with LITT. And so really, as long as you have lesions that fit the limitations of LITT, this is a great use for LITT. And that goes for radiation necrosis as well. Newly diagnosed metastatic lesion, I think, is a tough sell. Surgery is typically easy for a lesion that's large enough to need resection for metastatic disease. If it's small enough that you're not going to operate, that means you're probably going to deliver SRS, which is the gold standard and very, very effective. So it's hard to kind of rationalize going in with the laser when SRS would probably be just as effective at local control in a case that you would not be on. And if it's large enough to need surgery, LITT's probably not a great choice in any event, and you're probably just going to offer resection. So that is a summary of that. And I think as the kind of final sentence of summary, recurrent lesions, radiation necrosis, and deep or difficult to access lesions that are less than 3 to 4 centimeters is kind of really the classic place where we find a use for the technology. That being said, and I think it's helpful to have that refresher, wanted to bring you into the cases now. We'll jump right into it. I'm not going to kind of call out for people to yell out answers, but I'll read the case. I'll give a pause for you folks to think about it. I'll tell you what we did with the recognition here, of course, that there's often more than one ways to skin a cat, more than one way rather. And then after this slide, I'll offer some explanation for what some of the considerations were for why we selected the procedure that we did here. But also, again, not saying that this is the only way to do it, but at least providing you the fact that we always do have a reason for what we do. So this is the first case. This is a 53-year-old right-handed male who presented with a new 4-centimeter lung nodule and a right visual field deficit, and the imaging you see above. This patient is presenting de novo, so does not have a prior cancer diagnosis. There is no tissue diagnosis for that lung nodule, nor for what is in the brain. In this case, we offered resection and obtained a diagnosis of non-small cell lung carcinoma. Unfortunately, they weren't able to access the lung nodule for some reason, just so you know. And then we did offer, of course, postoperative SRS to this lesion following resection. What were some of the considerations here? So why resection? Again, hearkening back, newly diagnosed metastatic disease, I think, is the toughest justification for the laser. In this particular case, too, the superficial location, if this was not a de novo met, does provide some limitations, but of course is not a contraindication. Like I said, you often can just place the bolt a bit more shallow. But this is obviously a very safe and simple open resection. The lesion's right there on the surface. It's lateral enough that the visual deficit is likely from edema and not from direct invasion of the eloquent areas. And of course, we need ample tissue here to allow treatment for this patient, because this patient does not have a diagnosis currently. Now, of course, a biopsy needle can get tissue, but having the whole tumor is always helpful as well. And then this patient initially, their neurological deficit of visual field cut was due to the mass effect from edema. Now, you could argue that treating with steroids might cool that off, and then using the laser and heating that area might only temporarily reintroduce the lesion. But the simple fact is that for some period of time, you're going to make that deficit no better and potentially worse, since it's due to the edema itself. And of course, if you offer resection here, you're able to fix that deficit for that person almost immediately. He woke up, and within, I think by the next day, his field deficit was resolved. So you may recognize this image. I've changed the story for you now a little bit. So 53 right-handed male presents 1 year post-SRS for a known left occipital non-small cell lung carcinoma metastasis, one that perhaps you resected about a year ago. Right visual field deficit again, and the imaging you see above. The lesion has enlarged on 2 consecutive surveillance scans. And of course, he was symptomatic, so probably got scanned for that as well. I think this is great. I think no matter what you answer here, between the 2 things we've put here, you're going to be right. So let me tell you the options for LITT versus resection here. In this case, this wasn't a real case. I obviously just recycled the same image but changed some parameters, so I can't tell you what I did. I can tell you that nowadays I'm probably more inclined in instances like this to offer LITT, whereas when I was first using the technology, I probably would have been more likely to use resection until we discovered ways to avoid some of the pitfalls for superficial lesions. So what are the arguments for LITT? Well, it's a radiographically progressing MET that's received SRS, so it's often going to be scarred or stuck to surrounding white matter. There are some obviously perceived issues for wound healing, particularly for a superficial MET that underwent SRS, where those beams will potentially not spare the skin as well as they might for a deep lesion where they cone down. So, it's sometimes no fun to scrape these radiated lesions off of the surrounding white matter, which has been radiated itself, and again, maybe stuck. The arguments against LITT here is that, well, you know, sure, it may not be any fun, but this is still a pretty superficial lesion. It shouldn't be too hard to distinguish borders with the surrounding brain. And again, you're trying to also think about alleviating this patient's mass effect induced neurological deficit in the form of a visual field deficit. So I think that this is a very gray area, and I think it really becomes what you're most comfortable with in these types of instances. But I also think you're not wrong with whatever you choose here, and I will certainly say that LITT is a very viable tool to use here. Some additional considerations that I did want to bring up here. So we've done a lot of retrospective studies, and we're actually about to hopefully begin a clinical trial, prospective randomized trial, looking at a variety of questions surrounding combination of LITT with other procedures, including SRS, and especially SRS for recurrent lesions where biopsy reveals that it's actually recurrent metastatic disease and not radiation necrosis. And our retrospective data sets show that if you have this question of progressive disease versus radiation necrosis for a radiographically progressing post-SRS lesion, and you biopsy that lesion and it proves to be radiation necrosis and you laser it, that is generally sufficient to take care of it. If, however, your biopsy shows that you've got true progressive disease, what we've also shown now, looking at retrospective data sets between us and Cleveland Clinic and also WashU's data, we've combined data sets, is that actually the combination of LITT and then post-LITT repeat SRS for true progressive disease is more effective than either of those two treatments alone. So obviously LITT alone for recurrent disease will have some efficacy, some surgical efficacy. SRS alone for biopsy-proven recurrent disease will have efficacy, but the combination is actually quite effective. I didn't put the data in here, but it's very, very convincing. We presented it at the last, I guess it was CNS meeting, and we're in the process of initiating soon a prospective trial to look at the same question, although we suspect that we will not see equipoise. So the point here is that if it is progressive disease on your biopsy at the time of LITT, or at the time of open resection for that matter, if that's what you chose to do here, the patient should receive subsequent repeat SRS. And another thing that we have found ourselves and Cleveland Clinic have a lot of experience with this, if you are post-LITT and you are delivering that repeat SRS, fractionating that SRS, even for a relatively small lesion like this, appears to be better and probably certainly reduces the risk of subsequent radiation necrosis. So just a little bit of an aside that I wanted to discuss. Additional sidebar. For those of you who haven't done a lot of LITT yet, there is a very, very specific set of images that you will encounter post-lesion treatment that will drive your radiologist bonkers. And it's also important that if you're going to use the laser, that you're following these scans, because if this person's coming to your institution from another institution and decides to get their repeat MRI back closer to home, you're almost assuredly going to get a panicky call from either their radiologist or their treating oncologist or the patient themselves saying that the radiologist has called this progression. And we've now come to realize that there's, again, a very specific pattern. So about 1 to 2 months out from treatment, what you're going to see is a slight enlargement of the lesion oftentimes, but what becomes very much a thin eggshell of enhancement. And in this particular case, this was the first patient I ever treated. And so at 6 months, when I saw it starting to kind of get fuzzy again, I got nervous that I hadn't done much, but that trend keeps continuing. And at 10 months and even a year and a half post treatment, things really retract into kind of a small gliotic scar. But this right here is a very, very typical time course. It can be faster than this, which I'll show you on the next slide. But you have to familiarize yourself with this pattern. What that also means is that things like RECIST and other criteria are not helpful. And so we are also in the process, our group, of basically trying to get very definitive parameters, objective parameters that can be applied to these scans that can aid radiologists with labeling based on the total volume of contrast enhancement and based on curves that we've now used hundreds of patients to form whether or not you're within the typical curve or outside that curve, and whether or not, therefore, you need to be concerned that you may not have amply covered the lesion with the laser. So more on that soon, hopefully. I also think it's worthy of noting that this was an 80-year-old guy who had had a resection for a metastatic lesion that then had been SRS twice, and this was a lung cancer metastasis. So this is someone that years ago you might have not expected a tremendous amount of survival from, and I think it's worthy of note that just a couple of months ago, and he had been my first case, he passed away 5 years after treatment at the age of 85. We did promise you some imaging for more rapid resolution. So this is an example of somebody, also you can see 77 non-small cell MET, and the location you see pictured here was enlarging, got the laser, and had a much more rapid, and I have to say this is one of the fastest resolutions I've seen, much more rapid resolution on imaging, where by a month and a half the lesion had already started to retract in on itself. And at 3 months and 5 months, you can see that kind of small and almost non-existent gliotic scar that took longer to develop in the first patient, and I think generally does take longer to develop. This was someone that we indeed biopsied and lasered. Pathology in this case was radiation necrosis. I'll give a small aside here. We've also published a retrospective study showing that if you biopsy a radiographically progressing MET that's been SRS'd, if you biopsy that lesion because it's progressing in basically the first 9 months after radiation, it's about a 50-50 shot. So about half the time true progression, half the time radiation necrosis. And by the way, if you see mixed pathology, which of course is very frequent, I'm labeling that as progressive disease because there's cancer in there that's viable. If, however, you're outside that 9-month window, we typically saw a shift to about a 90-10 split, where 90% of it was radiation necrosis. Now, the numbers, it's 35 patient sample set, so it's not huge. So the numbers I don't think are as important so much as the concept that the further out you are from radiation, the more likely that is to be radiation necrosis. And people who fail radiation tend to do it early. So you might have a relatively high suspicion if this person's 2 years out from their SRS, that it's most likely going to be radiation necrosis just based on time course, forgetting any other imaging characteristics, etc. So some considerations for case 3. So why did we offer LITT here? For a couple of reasons. First off, this is a radiographically progressing lesion MET post SRS. So you can see it kind of wiggling through some of the sulci down there at the bottom of the sulcus there, and then going deeper than that as well to the corpus callosum area. So it's appropriately sized. It's less than 3 centimeters. It has some deep extension. There's some areas there that'd be kind of no fun to peel stuck radiated tumor off of. I think this is a great use for the laser. And your right frontal, I mean, you're not going to hurt anything here. So this is a great use of the laser, and this patient did very well. This is a 65-year-old right-handed female, known triple-negative breast carcinoma, who presents with the surveillance imaging that you see above. You can see a minimum of 4 to 5 enhancing lesions there, maybe even 6th. So, and all I would say probably, a centimeter or less. This is someone who just needs multifocal SRS. So what are the considerations here? You have multiple small, newly diagnosed metastatic lesions. You have no dominant symptomatic lesion that would warrant resection. Again, remember this was discovered on surveillance imaging. And if you did have a large enough lesion that might warrant resection, I would favor resection over LITT if so. If it's large, symptomatic, it needs to come out. Laser is probably not the best choice, and probably it's not too difficult to offer surgical resection. 54-year-old right-handed man with non-small cell lung carcinoma of the left lung presents with unsteadiness and a left visual field cut. Imaging that you see here, no prior brain metastasis, so these are newly diagnosed lesions. All right, this one I bet will stir a little bit of controversy. Resected both of these lesions in the prone position, separate incisions, one supratentorial, one infratentorial, both short linear incisions, and very small keyhole cranies. So why did I do that? First off, before anyone gets too much on my case, there are reasonable data for resecting multiple dominant metastatic lesions, up to as many as 3 in the literature. But typically, I guess most of the times when I've done it, it's been 2 lesions, and it's probably only been a handful of times. But I think this is a good instance for it. First off, they're newly diagnosed, so I think I'm not going to offer laser typically for this, and these are on the cusp size-wise of what I'd want to safely put the laser in, particularly with one of those lesions being fairly large and in the posterior fossa, causing a lot of swelling there where you can already see some mass effect on the fourth. It's probably not going to be your smartest move. You can do it through a single position, so you don't have to take down your drapes and reposition the patient. That is obviously not the most important consideration, but it's certainly something. And I think that covers it. And you've got actually both of these lesions also are symptomatic. So I think surgical resection from even just a palliative standpoint, or being able to rapidly offer symptom relief by alleviating mass effect and kind of quality of life are considerations for me. So in any event, resected both of these lesions as noted, and then patient, of course, got postoperative SRS, even though I didn't put it on this slide. So a sidebar here, because we did mention the posterior fossa. So the question will always come, do you have experience doing LITT in the posterior fossa? Can it be done? I say yes, it can be done. It needs to be done carefully. It was years of doing LITT before I decided I was willing to wander into the posterior fossa. I wanted to feel like I had a good sense for what the technology might do in that area, or just in general. And so, of over 100 cases now of the laser, I've done 2 in the posterior fossa. And I think, the Monteris folks will tell you, I'm a conservative user. I believe very, very strongly in the technology, but I don't believe it's a toy. And so, if anybody is using LITT conservatively out there, it's me. And yet, we amass a tremendous number of cases. And I think that when you look at this is where you have to be conservative. So what are the instances where I'm willing to use it? First off, it has to be a fairly small lesion without tremendous amount of mass effect. This thing that you can see here is maybe 2 centimeters, and you don't see a ton of edema. You don't see, it's not deep in the peduncle. It's not deep in the vermis. It's not compressing the fourth. There's no signs of hydrocephalus. There's room to create some swelling there. So that's number one. So from a safety perspective, of course, safety first, that's number one. There are some other considerations that really need to be taken into account here. So for those of you who have done the procedure, typically you're in a supine position, and you've got a laser maybe coming out of the top of the head, and there's a driver and a bunch of cables that are coming out of the head, and those typically you're trying to orient the head and the surgery so that those cables don't have a big bend, a 90-degree turn, so that they'll fit nicely in the bore of the magnet. So it's and I teach my residents this all the time, because they always want to put the lesion at the top of the field, just as you would typically for an open surgery, and that's not the case here. Really, you can drill and place a biopsy needle on a laser horizontally. It doesn't need to be this, right? So the fact is that oftentimes you want to be drilling in this orientation if you can, so that the cables are going to fit nicely into the bore of the magnet. And so the residents often have to unlearn how they think about positioning a patient for these cases, and I had to do the same when I started doing this, and you only need to make a couple of mistakes before you figure it out. And so, if you think about it, that creates a real issue for prone surgery. So if you're going to face somebody prone and then have something coming out this way, typically down, those cables are going to have to make a very big turn back towards the bore of the magnet. So prone surgery, where typically that laser is going to need to angle upwards toward the tent, by definition, that's going to have you coming out away from the bore. And so people don't think about that, but it creates limitations. So what I'm saying here is that generally, if I'm going to do a LITT case, I want 2 kind of positioning and anatomical criteria to be met. I want to be able to position the patient supine. So I learned to do acoustic neuromas through a supine position and come retrosigmoid. Now, obviously, a lot of people don't do that. They do it lateral, but it's very accessible. And in fact, the shoulder's not in your way if you think about it. So In this particular case, you can position somebody with a bump under their shoulder, head turned, and you can have the laser coming out from retrosig, and it can just kind of angle straight towards, a little bit more towards the magnet. So I'm looking for patients where I feel confident that I can kind of come from a retrosigmoid approach and leave that patient supine. And as you can see here, that's exactly what was done. You can see on the axial and then on the picture below that you have a really nice straight retrosigmoid shot into that lesion. And you can actually see our laser catheter there inferiorly in the picture. So that's one criteria. I want to be able to come retrosig. The other thing, and for those of you who have done a lot of posterior fossa surgery, you always kind of want to know what the slope of the posterior fossa is, right? So if you've got a steeply angled posterior fossa, think about trying to do like a supracerebellar infratentorial approach in that person. It's a nightmare, right? Because it's just a tough angle. So, but if you have more of a kind of perpendicular tentorium, that gives you a larger window of access into that cerebellum and allows you to come more straight out rather than having to angle steep up. Because if you have to angle steep up, when those cables come out, they're going to have to make a almost 180-degree turn to come back towards the magnet, particularly if you're prone. So in general, I'm looking for a favorable anatomy. And if you look at the rightmost image here, that's your sagittal. And you can see that this person does not have a steep slope of their posterior fossa at all. In fact, it's almost flat. And so that provides you a lot more wiggle room with thinking about the angle of your laser as you come in. So these are a lot of criteria, as you can see, that I've kind of set myself up to try to satisfy before I'm willing to do a lesion in the posterior fossa. And as you can see, that means that I'm not going to do a ton of them. But they are doable, and there are single institution published series out on working with them. And I think it obviously depends on your comfort level. But these are the things that matter, and these are the considerations I would make when trying to make those decisions myself in my own practice. Questions on that? That was a bit more involved with that sidebar, so maybe that sparked some questions. This is a 65-year-old right-handed male with a known left funnel lung non-small cell MET that had been SRS'd in, we'll call it January 2020, so almost a year ago. Presents with word finding difficulty, confusion, and the imaging you see above. I think there are people that would laser this. I have no doubt about it. I'll tell you why I didn't, but this is someone I offered an eyebrow resection. The pathology did show progressive disease. And again, this is a person who's 9, 10, 11 months out, so that's not too shocking, about a 50-50 shot. And so they, of course, got repeat SRS afterwards. So why did I resect here rather than using the laser? Well, I think laser would be viable. So the arguments in favor of LITT here, recurrent MET, we've talked about the fact that recurrent disease is a good use for all the reasons, stuck, all those reasons we've talked about a few times here, which are listed there, of course, again. It's deep, right? And so often deep lesions are a good use for the laser because you don't have to destroy a bunch of brain getting there. What are the arguments against LITT? These are obviously the arguments that weighed more heavily in my mind. It is a somewhat large lesion, and even though it's not super large, the kind of little protrusion superiorly there makes it oddly shaped and makes it so that you're probably going to need 2 trajectories, and you're going to need a fairly decent sized burn to cover that whole lesion. So, well, that's no big deal. Why worry? Well, if you look at this sagittal scan here, what you'll notice is that this person has a just tremendous amount of edema. And that mass effect has given him speech difficulties. This is a left frontal lesion. He's got kind of a paucity of speech. He's confused. If you create a whole bunch more edema in this guy, you're going to really knock him down, potentially for the count. So I really hesitated to do that here. I wanted to get him his speech back. I wanted to get him his mental status back quickly. He had just had so much edema that I was worried about creating more. And so simple resection through the eyebrow, and he was back at it pretty quickly. But again, I don't think you'd be wrong to laser here. I'm just offering you the rationale that I went by and that I was happy that I did. So, any questions?
Dr. Fecci? Yeah. So I did get one person submit a question asking if you have any slides with pictures of positioning setup for the posterior fossa cases.
That is a fantastic point. The short answer is I did not, but I am, really the only difference is that I position the patient supine with a bump under the shoulder and the head turned. And then what I also tried to do is I tried to flex the chin just a little bit, because if you think about it, that's going to allow the angle to be more towards the bore of the magnet as things are coming out. Whereas if the chin's extended, it's going to come out this way, which is the wrong way, because you want things coming out more towards the top of the head. So I did give a little bit of chin flexion. To some degree, it's a little bit of kind of, as you're there, you've got to fiddle with things, right? You've got to position yourself in such a way that you really want you're trying to minimize the bend and curvature in those cables. And we have an intraoperative MRI, so we're always hula hooping as that patient is pinned in the Mayfield to make sure we're going to be okay. I don't tend to do cases in the lateral position for that reason, so I'm trying to make myself supine, because it's particularly someone with bigger shoulders, it's hard to get them in the bore sometimes. So I'm trying whatever I can to either be straight supine or straight prone. And prone, for the most part, I'm not going to use unless it's something that's like, maybe like a medial parietal lesion like this, where it's past the vertex, and so it's a little bit easier to be prone. That would be the kind of classic prone case for me with the technology. I think the other thing to remember is that if you have an IMRI and you're doing this in an intraoperative magnet, you are limited further in your positioning, or at least by your Mayfield in those IMRI or IMRIS Mayfields, and those generally have to be pretty much straight perpendicular. So that's also providing you something that you've got to be careful about as you position the patient, because otherwise you could be putting a pin right in front of where you need to be, and you won't have the luxury of being able to turn your Mayfield like you would in a non-magnet case. So just those are the things. I mean, and again, for whoever that is that's asking, I'm more than happy. I don't know that we took a picture, but if we do it again, I'll make sure I do. And if I have one, I'm happy to try to find it and send that to you over email with all information removed, of course, if I can find one. So maybe either Keith or Bill, if you're willing to get some contact information for you, I'm happy to try to find something.
Yes, we have record of the question in the name, so I can get that from you and then we can send it to them.
Great. So hopefully the added explication was a little bit useful there, though. Case 7, 58-year-old right-handed male with a history of left temporal GBM, status post resection and external beam radiation therapy 1 year prior, who now presents with radiographic progression seen above. So we did biopsy and laser here. In my earlier days of laser, I may have been less willing to do this because of the periventricular nature. But again, we can get pretty darn good coverage. And if you're getting 95, 99% coverage, that's pretty good. And again, because this is a recurrent GBM, I think there's a narrower therapeutic window for open resection, which is why 85% of recurrent GBMs in this country are not resected. And so I think that if you can just do something minimally invasive on a prior surgery, stuck dura radiation lesion, if you can just slip a tiny incision and slip a laser down that, all the better. Might as well provide myself some visual cues here. So some other considerations besides the kind of previous radiation, prior surgery, all those wound healing concerns. This is actually an appropriate size and location, and it is a slightly deeper lesion with kind of difficult access. You've got dominant temporal lobe there. I will note that we did get a functional MRI on this patient preoperatively. I don't necessarily always trust fMRIs to give me specific areas to avoid. I would generally want to do an awake mapping regardless of my fMRI results if I was doing this as a resection. But in general, the laser, you can come a bit more posterior, or you can kind of stay away from speech representation from fMRI data. I will say that some people have done LITT cases awake, I'm not 100% sure in this particular case that I would understand that. I think most of what you'd be concerned about here would be your entry point, and by the time you have a deficit from that, it's too late. I can understand, I guess, if you're sneaking in from behind on a motor lesion, coming parietally, and you're going to burn, and you're worried about developing a deficit intraoperatively. But I think it'd be very uncomfortable for someone to be in the MRI being burned. But I also think that you're looking at the lesion borders. So you may be creating edema that produces a deficit, but you can see where you are on the MRI. You know that you're in the lesion borders or not. And if you've colored outside the lines, then you might expect a deficit if you're in the motor strip. And so I think the simple advice there is don't color outside the lines. Yeah.
Got a question for you.
Sure.
Are there any occasions that you might choose laser ablation over SRS? And
Never.
How do you view these two technologies working together or apart?
Yeah, so I would say think of this as a surgical tool. This is an alternative to resection, to open resection. And you would never use an open resection of a metastasis to replace SRS, because SRS is far superior to open resection in local control rates. I mean, it's not even close. And SRS, no offense to the Monteros folks, is way more specific at delivering energy exactly where you want it than the laser. So SRS is the gold standard in treatment for metastatic disease. We use surgery as an adjunct in newly metastatic disease to offer symptom palliation and alleviate mass effect, and to offer cytoreduction when it's going to help SRS. So if you're going to look at a newly metastatic patient, your decision tree is, am I going to just give SRS, or am I going to operate first and then give SRS? And the lesions that we resect are lesions that are large and symptomatic, and those aren't the best lesions to laser. So that's why I think newly diagnosed metastatic lesions are a tough argument for the laser. And if it's a small, deep lesion sitting in the thalamus, why go in there surgically at all if SRS is going to offer you 90% local control rates? That's where I think there's a problem. Now, where the role of open surgery becomes less clear is in recurrent disease. So, and oftentimes you're going to need a diagnosis, right? So our radiation oncologists, if we get radiographic progression of a metastasis after SRS, they're never going to want to go back in there and repeat SRS it without proof that it's not just radiation necrosis. Because, if you liken it to, I always use this analogy, if I got stung by a bee, the cure for that isn't to have another bee come and sting me in the same spot. And symptomatic radiation necrosis is only going to get far worse with further radiation, and the problem is that you could have avoided that with a simple procedure or some Decadron. And the problem is that a lot of times in the community, folks are unfortunately not getting biopsied, and people just give more radiation because they assume it's treatment failure. 2/3 of what we see on biopsy when you combine the people that are right after SRS or far out from it is radiation necrosis, take all comers. And so 2/3 of those people are inappropriate for more radiation, and they're going to get worse. And then what happens is someone just puts them on hospice. That's unfortunate, because there's still lots of treatment options for those folks, not just steroids or Avastin with the laser. So where I see SRS is the thing that they have to get if you have a histologic diagnosis of metastatic or recurrent metastatic disease. The question is, are you going to offer them cytoreduction before that? And I think that the combination of surgery plus SRS definitively in any study that's out there has been better than SRS or surgery alone. And I think for recurrent metastatic disease, those data weren't out there for LITT and really are tough to come by for surgery, frankly. But I think retrospectively now we've definitively shown that, killing that recurrent lesion with the laser as an alternative to an open surgery, and then just as you would with an open surgery, coming back in with SRS, that combination is most effective. So I guess what I'm saying is you're always deciding about whether it's SRS alone or SRS plus surgery. If you're offering a surgery, now you have a different decision tree of, am I going to offer resection or am I often going to offer LITT? So it is a surgical tool to be used in lieu of open surgery. It is not a radiation tool to be used in lieu of the gold standard for radiation. Does that answer that? I hope that was clear.
Yeah, I would say that's good. Yes, thank you.
Okay. Great. That was a good question. Case 8. So this is a 69-year-old right-handed female with a known history of ovarian cancer and multiple intracranial metastases. You can see 2 of them here, of course. They've been treated with SRS about 7 months ago, so you're again kind of on that cuspy period. So you're saying about a 50-50 shot. Now with 2 radiographically progressing lesions, it should say, sorry, presents with hesitant speech and generalized weakness. So before, where we actually just talked about resecting 2 lesions, those were newly diagnosed, they were large, they were symptomatic. These are recurrent lesions. They've been radiated, they're smaller, and all the reasons that we use the laser in a single lesion that's been radiated in the past. Now you've got 2, and pathology was radiation necrosis in both lesions. So these are small. These are either one of these lesions would be appropriate for LITT, and so because they're both progressing, this is one of those rare instances where I dropped 2 lasers for all the reasons I normally would. And then there's another interesting benefit here. You might say, well, you'd have to flip the patient. It's not true. You've got to unlearn what you think about positioning people for these cases. This is a person that was positioned straight supine. Because if you think about it from a coronal perspective, these are both relatively high lesions. So you essentially have, like this, 2 lasers coming out, again, straight towards the bore of the magnet. So no problem, piece of cake to drill here and then to drill here. Single position, didn't have to move the patient, piece of cake. You place both bolts at the same time. You put the laser down 1 bolt, you scan, you cook, you roll the magnet out a little bit, or sometimes you can just do it like tuck yourself into the magnet, get dizzy, take the laser out and put it into the other bolt, and then just go back to the control room, which is typically what we do, frankly. I mean, it's no trouble at all to simply pull the laser out of 1 bolt and put it down another. So this is very efficient. It is not twice as long because you're just basically drill, bolt. It does not take us twice because most of the time is the setup and the takedown. So it's very, very simple to do this in, probably all told you're in the operating room for 4 to 5 hours to do 2 lesions at the most. So, okay, so questions there before I do a sidebar. So I think that might raise the question of, okay, well, that's 2 lasers for 2 different lesions. What about a 2 trajectory laser for a single lesion, which we kind of broached earlier? When would you do that? Well, this is a case where I would do that. I already gave the answer away, but actually this one's not set up as a case. So, just like posterior fossa, yes, it also can be done, but carefully. You have to be in a place where you're not worried about creating a decent amount of mass effect. We always had a joke in where I trained that it's not even brain, it's right frontal lobe. That's a great place to get some experience where you're a little concerned, right frontal lobe, right? So here it is. Obviously, you've got edema tracking back into motor. There's not a ton of edema around this lesion. In this particular case, it was a right frontal anaplastic oligo that had been resected and radiated 6 years prior and is now radiographically progressing. This is different than the MET case. METs, if they progress after SRS, you're thinking, 2 years out, it's probably radiation necrosis. Gliomas and GBMs, tumors that we know come back many years later, or not even many years later, and which have just gotten external beam radiation therapy, that's a different beast, right? So this is more likely to be disease progression, which it was. But in any event, it's about, you can see I put a marker on it, it's about 3.8 centimeters. It's too big for 1 laser, but you can easily cover it with 2 trajectories there. There's not a ton of symptoms for this patient, not a ton of mass effect or edema. It's right frontal lobe, good place to start. This, I think, is a very, very viable use. It's a deeper lesion as well. It's not sitting right on the surface. I think this is a very viable use of a double trajectory for a single lesion. Well, we are on the last case. For those of you that have seen me talk before, you know that this case typically finds its way into a talk just because I love it and we love the video. But I think it's still a good case to review. This is a 13-year-old right-handed male who has left-sided numbness, headaches, paresthesias, some visual changes. Gets the imaging you see above. It may be subtle, but you should be able to see the kind of T2 bright lesion in the right thalamus there. And that's, of course, concerning in this age group, that appearance for low-grade glioma. So what would you do? I would think this one would be pretty straightforward for those of you who've been watching this talk. This is a great, great use of biopsy and laser. You want the biopsy, of course. We always biopsy every time we LITT. We want a tissue diagnosis. It helps the oncologist. It helps the radiation oncologist. In this case, you need to know what this kid has. It was a low grade, of course. And then, again, you've got a safe trajectory in. We took essentially a DBS style approach. I brought one of my functional neurosurgeons in, colleagues in to kind of help me plot a trajectory into this. And then we had a pediatric neurosurgeon with us as well, just so we had all our bases covered. Not going to mess around in a 13-year-old with thalamic lesion. And we got a safe trajectory in and lasered that lesion. He woke up with some initial weakness that resolved very quickly and is doing well. And he's a snarky, wise ass of a kid. So I think that these guys are taking control of the mouse for me and are probably working on getting this video started in a MacGyver-y way.
Dr. Fecci, everything is working fine. Right hand still works very well. The left hand is doing perfect. Oh, this one won't go down. What? What? I don't get this. Thank you so much and a Merry Christmas.
Yeah, snarky little kid, but he's still doing great. We've actually, this treatment was now 2 years ago, and he's got no deficits. He's fantastic. No evidence of disease progression. Looks great. And these guys, the Monteros folks. Oh well, some considerations here. I think you're used to these now, but if I'm sounding like a broken record, then that means that I've done a good job of drilling some of the principles into your head. So. No pun intended. So newly diagnosed glioma, presumed now. So when do we use it for newly diagnosed glioma? Well, surgery is still the gold standard. That's where we know the role of resection. But where don't we have such a great role for open resection? Deep or difficult to access lesions. So this is a small lesion, well, easy to cover. You know, if this is a 5 centimeter thalamic mass, bad idea. This is a less than a centimeter thalamic mass, great idea. No big mass effect, not too worried about obstructive hydro or anything. It's safe to biopsy, so it's safe to laser. And we went a little supramarginal. I mean, you'd have to in a lesion that small with the laser, but very good outcome, which I was of course nervous about. Before we start this video here, I'll tell you that another great use of the laser, and it's starting to get used more and more. And actually, I'm stupid. I should have put it in this talk, but I will include it in future versions. Is hypothalamic hamartoma. And that's a bear to do an open resection on. We had an 8-year-old kid, same deal, brought the pediatric neurosurgeon in. We plotted a trajectory down to the hypothalamus. This kid was having gelastic seizures, like 7 or 8 a day, completely crippling. And I've been having them for years. So we lasered the hamartoma. He left on post-op day 2 or 3, seizure-free. Immediately. It was unbelievable. I mean, I think we rarely have instances in neurosurgery where we can be that helpful to people and make such a dramatic difference in their lives. And that was just a great one. So that's a great use of it because it's so much easier to get a biopsy trajectory into a hypothalamic hamartoma than it is to get knives and bipolars and everything else. So in any event, with that said, this was the intraoperative imaging from the thalamic lesion. And what you can kind of see here is that we did go supramarginal. This is the blue line kill. So we're kind of outside the lines for a little bit, but we knew where we were comfortable being outside the lines and got a good coverage on it. And I know that in future talks and in future seminars like this, the Monteros folks will be looking at kind of more the technical aspects of the procedure and like really right down to the nitty gritty and details, the real logistics. And there'll be a lot more explanation around what you're seeing here and et cetera, but at least to just kind of give you a sense for what that looks like. And you can see the trajectory in there, so forth and so on. So any questions?
Where did you start as a new surgeon with laser ablation, and where would you recommend a surgeon entering practice begin with laser?
I think that's a fantastic question. The first overwhelming majority of my cases were radiation necrosis. It was the easiest justification for me at that time because there often weren't great options for those folks. The laser works great against it. And in fact, when I first started, so it was radiographically progressing Mets. That was the easiest thing to come my way. I had started this brain Met center. They were getting referred to me. And I had operated on a bunch of them prior to that. I was like, well, this isn't really a lot of fun, but that's okay. You know, we'll do it. And we take these things out of the motor strip, and like you're stripping this radiated stuff off the corticospinals. It's just terrible. We do it with mapping, et cetera. And so after what I started doing is I would do radiation necrosis, and then I'd get my biopsy, and if the biopsy said it was recurrent disease, I'd switch to an open resection. And if it said radiation necrosis, I'd laser. And then eventually, it wasn't very long before I was like, well, that's kind of stupid. You know, it's the same lesion you should see. And so we did. And frankly, plenty of others had seen before me, but I just was, you know, I was being conservative. And of course, it worked great once we started doing it. You know, the difference is that I think for radiation necrosis, sometimes we're a little bit more comfortable just getting the yellow line or between the yellow line and blue line out to the margins of the lesion, particularly if we're in an eloquent area. If you've got recurrent disease, you really want to blue line it. But keep in mind that if it's met, you know, you're going to come back in with radiation. So what's the goal of surgery? The goal of any surgery, whether it's resection, whether it's laser, is cytoreduction. You want to get to that 90-95% mark so that your radiation is going to be more effective. And it will be. So, you know, wrecking somebody or injuring them with a surgery, which is then going to obviate the benefit because they're going to be low KPS at that point that they would receive from their subsequent treatment, you haven't done that person any great services. You are better off cytoreducing 95%, leaving them intact or with a very transient deficit, and then coming back in with the radiation if it's recurrent disease. And if it's radiation necrosis, you don't even have to blue line it. It's going to disappear. You saw the imaging. I can show you scores of imaging sets like that where this stuff just goes away. And we've really, I think I've had maybe one patient that didn't completely respond with radiation necrosis where it still wasn't radiation necrosis when it progressed and it was rebiopsied. Almost everybody else, if they progress later, then they end up usually getting biopsied and it shows progressive disease. I think recurrent GBM, if that's something you see, is another great place to start. All GBMs recur. Surgery in those folks is painful. There's a much narrower therapeutic window for providing them benefit. Their craniotomy incisions, you know, if you reopen those, they've been radiated, they don't heal. Just make a ½ centimeter incision, laser, assuming the lesion is safely approached and is only like 3 centimeters or less. That's a great use for the laser. I think in places where open surgery still is the gold standard, newly diagnosed GBM, newly diagnosed metastatic disease, it's a harder sell, unless you have something like what we showed you, which are deeper lesions in the thalamus. Deeper lesions in the thalamus, not where I would start. So on the flip side, you know, I wouldn't be too worried about being in a not very eloquent area of the brain to start. I mean, wherever that is, right parietal, temporal, you know, provided it's small enough that you're not worried about mass effect. Right frontal, you know, left parietal away from speech, you know, lateral occipital on either side. Those are all fine places to start, but you know, don't start in the thalamus. You know, get comfortable with your workflow. Get comfortable with how you're, how you're going to push the heat out. Another gem is I only use the side fire laser. I never use the kind of 360 degree that you'll see a lot of the epilepsy surgeons use in the mesial temporal lobe. I want to be able to sculpt that lesion. And if your trajectory is off a little bit and you're not perfectly down the center, which it's going to happen, and plus the lesions aren't perfectly spherical most of the time anyway, as you saw from most of those, of course, you want to be able to push the heat out more in one direction. The side fire is going to let you do that. So, my recommendations is start with radiation necrosis, start in a non-eloquent area, start with a case that's clearly going to be single trajectory, and use the side fire. That's my start there kind of speech.